Buenas noches a todos. Aquí estamos transmitiendo esta plática que se dio en 2016 en el Congreso Europeo de Anestesia Regional, que a pesar de ser de anestesia, toca un tema muy interesante que es la punción en plano o fuera de plano, las indicaciones y características de cada una de estas formas de hacer la punción ecoguiada. Espero que sea de su agrado y que podamos tener acceso a más y más pláticas cada vez de origen internacional para poder compartirlas con todos ustedes. Gracias por acompañarnos. Aquí está la plática.
I'm from the UK. I work in Norwich, and this seems like a very easy topic to cover. And I think when you start with regional anesthesia, you feel this is easy. I'm going to use in-plane or out-of-plane. It doesn't matter. I'll just go whatever it showed me. But there is some evidence out there that helps us make the correct choices. So I'll go through it. So yeah, I've got no disclosures to make, no sponsorships. I'm going to do a slight overview of the historical development of blocks, and I think this has played some influence on how we've actually been taught and how the teaching programs have worked in different parts of the world. There's advantages and disadvantages to each of these methods, which you possibly know of already, and then I'll briefly go into specific blocks and just maybe give some anecdotes, some evidence about things that I think is important when we make our decision about whether to use an in-plane or an out-of-plane technique. Ultrasound-guided interventions was actually more established amongst radiologists. And they were the first ones with ultrasound, and maybe some of the cardiologists as well, obviously. And they would use a lot of short axis views when they performed their procedures, because most of their procedures were based around vascular access. In the UK, the NICE, National Institution of Clinical Excellence, published guidelines which suggested that we use ultrasound for the insertion of central lines, CVP lines, and that's really how ultrasound became well established in the UK. Now you'll notice that because we use ultrasound in that particular way, we often stick to that particular method that we were shown initially. Now the Austrians, Stefan Krapell, Peter Marhofer in Vienna, they started publishing about ultrasound-guided regional anesthesia, and this was back in, I think, 94. And this was really the start of this revolution that's now taken over. If we look at the evolution of these blocks, I found that when I'm traveling around the world teaching blocks, I find that the Europeans, and I would say Austrians, Germans, French, when I've been there, that they seem to use the short axis view, and they seem to use it with nerve stimulation techniques. So it's a very familiar technique for them, and all they've done is really just apply the ultrasound machine to an already familiar technique. The advantage of that is obviously that you can use your surface anatomy to great benefit. In North America, the Toronto group obviously was also quite prolific in publishing there, and it looked like there was more emphasis on actually seeing the needle. When they were training their residents, I think it was quite important that they knew exactly where the needle tip was, and they tend to use the in-plane technique more often. In the UK, a lot of people have stopped using the nerve stimulator technique, but obviously with triple monitoring that could be recommended, but that's another lecture. So we have this development, explosion of ultrasound, different parts of the Atlantic, North Americans in the UK teaching and training in one particular technique, the French, the Austrians, the Germans in another particular technique, and I think people tend to stick with the technique that you were initially shown. So if your professor, director showed you a particular technique in plane, then you tend to do it in plane for a long time, until you learn something better or until you have a complication. Just to get the terminology right, if we talk about in plane, we are actually talking about the needle. This is a short axis scan or a cross-sectional scan at the top, and then a long axis or a longitudinal scan. So really you can have 4 different techniques if you really want to. Most of the time we're trying to find a good view of the target nerve in the cross-sectional axis, and then you can have your needle out of plane or in plane. I've not really used the longitudinal scan and the out of plane technique, but occasionally for sciatic nerves I've used this particular technique where we have a longitudinal scan with an in-plane technique. This is sometimes useful for central line or vascular access as well. So these three, but these are the two that we'll be concentrating on today. If you look at the recommendations from ESRA and a combination of ESRA about the education and training of ultrasound-guided regional anesthesia, there's different components that we need to adhere to. It's really getting the image, capturing the correct image. And this is where the courses that we attend, the workshops that we attend, really just shows us how to find these nerves. And initially you think that's the most important thing, but actually once you start doing the block you realize that was the easy bit. So you have to acquire the image, you then have to optimize this image, and this is about ultrasound machines, about the correct frequency, the correct probe, correct positioning, things like that. You have to interpret the image, the surrounding anatomy of that particular image, artifacts, all that is taught. But it's very difficult on these courses to actually do needling on live patients. We often have phantoms, and there are better and better phantoms, high fidelity simulators being developed to help us with this particular teaching and training. And then obviously the local anesthetic injection and the spread of local anesthesia, depending on how we manipulate the injectate around the nerve. In that case, I quite like what I call a hydrodissection technique. So I like to place my local anesthetic in fascial planes and let it flood around the nerve, and I try not to have direct contact with the nerve. And I'll show some examples of that in the coming slides. But there are things that can help us with needle visualization. There are some tricks and tips. Whether you use in-plane or out-of-plane doesn't really matter. But it is very common when you evaluate trainees or novices, it's very common for them to lose the needle tip, whether that's in-plane or out-of-plane. And another study suggests that even after 100 blocks, some people are still losing the tip of the needle and advancing the needle without actually seeing the tip of the needle. And I think this is potentially a fatal error. The other particular problem is that the ultrasound screen projects the image. So normally, if you lose your needle tip, it's normally 20% deeper than what you think. And if you're doing a supraclavicular block, or there's a lung or an artery adjacent to the nerve, then that can be a particular problem. It's a very narrow beam. That ultrasound beam is just 1 millimeter, so you do need some PlayStation skills to keep that needle in plane all the time and visible. It is also three-dimensional anatomy. And the problem with three-dimensional anatomy is that we're projecting this on a two-dimensional screen, and that can also cause some trouble. You're also not actually looking at your hands. As practical people, anesthesiologists, we like to look at our hands as we perform a procedure, and with ultrasound regional anesthesia we have to look onto a screen. And there is very good evidence to suggest that if your brain, eyes, hands and screen, if that is in a good ergonomic position, you actually perform the task a lot better. But again, that's also another lecture. There are some help out there, so people have tried to have these mechanical guides, stick them to the side of the needle, and it's really for the interventional radiologists with the biopsies that they use, and actually it does speed up performance time, but the quality of biopsies for interventional radiology has not improved. But in regional anesthesia, we actually make slight adjustments to the needle as we inject around the nerve, trying to manipulate it, and this is why redirecting the needle in a guide can be quite difficult. Bantui sort of had a laser guide, which I got the impression when I read the article that he made it out of spare parts from a hardware store, but it seemed to work, and that was an optical guide using laser. Now, technology is improving all the time, and I'm sure with all the sponsorship that's available today, you'll see the different needles, and you'll have your particular favorite to use, and that's polymer coated or laser etching. The ultrasound machines are also improving, and also the electronic enhancement of needles are starting, where we magnetize them, or there's a piezoelectric current through them, all sorts of things. But again, there will be a lecture on ultrasound guidance and technology a little bit later. Let's stick to a few more other strategies. How can you, without all the extra help, just see the needle slightly better? When I say a heel-in technique for the needle angle, is that you actually try and minimize the angle between the needle and the probe so that you have a slightly shallower angle. And obviously, when you have a needle at 90 degrees to the probe, you will see the needle a lot better. And this is where the inline technique is sometimes quite useful, because most of the body structures are round: the arm, the trunk, the neck. So you don't really have to place the needle right next to the probe anymore. You can actually be a little distance away from the probe, get a shallower angle, and see the needle a lot better. We could just use much bigger needles. When we started with tap blocks, a lot of people were using 18 gauge, 16 gauge epidural needles, but again, patient discomfort is there. The maneuvers that you need for freehand control, which is what I would recommend, is the sliding, tilting, and rotating movements. And now things are improving dramatically. If you walk around with the sponsorship again with the ultrasound machines, they've got all sorts of electronic wizardry. It's almost impossible not to find the nerve, and it's almost impossible not to get your needle near the nerve. So 3D ultrasound is also out there. I have played with it slightly. It's a slightly big probe, so it's not always practical for the smaller nerve blocks, but it gives you a continuous image, 3 different sections, so you can have an in-plane, out-of-plane view all the time. Again, a few more strategies is just movement. You'll notice with the interventional radiologist, when they do out-of-plane biopsies, they are actually moving the needle quite a bit, and they use this maximum tissue movement or tissue plane movement to help them locate their needle tip. If all else fails and you're really getting lost, you can obviously just inject a little bit of local anesthetic or 5% dextrose if you're using nerve stimulation, and that can sometimes help you find it. And then micro bubbles has also been reported. This is the study is also the Vincent Chan group from Toronto, where they were looking at the performance using a needle guidance system and how this is helping novice residents performing the block, and obviously it helps them enormously. Just a sort of few basic things. If you're looking at the out-of-plane short axis advantages, the reason I think the Austrians and the Germans used it is because it's quite a pragmatic approach. It's close to the nerve stimulation techniques, and it's the shortest distance between the skin and the nerve. And that's entirely what you want. You don't want to unnecessarily cause tissue damage or pain to the patient. Our traditional landmark techniques are still completely valid then. We can use our normal landmark techniques to know exactly where our needle entry point should potentially be. So if you look at this interscalene block, normal landmark technique, all you would then do is just add an ultrasound probe to it and then carry on from there. So quite easy. You're not doing anything new, you're not doing anything more dangerous, and a lot of people are still using nerve stimulation when they're starting with a short axis technique. In my opinion, it is a little bit more difficult to actually follow the needle tip, to visualize it. Initially it's good, but as you move it, you can often see the shaft of the needle and not the needle tip, and that is a little bit problematic. If you have bigger nerves like the sciatic nerve or the femoral nerve and you're doing a short axis out-of-plane technique, you may only be able to put local anesthetic on top of the nerve, or you're going to go to the left or the right of the nerve. Whereas with an in-plane technique, I tend to be able to manipulate the local anesthetic a little bit better. So I manipulate it with hydrodissection technique, as I said, with fascial planes, and again I'll show you that in a moment. The in-plane technique, there's some advantages there. As a novice, as a trainee, you feel more confident that you can see the needle tip. Also, as a supervisor, as you are training, you can look at the screen, or the same screen that the novice is looking at, and if you, as the supervisor, cannot see the needle tip, then the trainee can definitely not see the needle tip either. So I think it is important, and it is a valuable way of teaching ultrasound using the inline technique, because you can check exactly where the needle tip is, tell the trainee to stop if you can't see the needle tip as well. And obviously when we talk about catheters, which I'll talk about at the end, a little bit later in the end, the catheter is already tunneled, so it does have that advantage where you don't have to especially tunnel the catheter again, depending on the particular block that you're doing. So, interscaling, that'll be my in-plane approach. And you will then see the needle tip reasonably clear. The plexus will be there. The patient just moves a little bit on the initial injection, and then you can even, if you do it properly, see the bevel between C5 and C6 there. This is another debatable point. How many places do we need to inject with this particular technique? But that's, again, another lecture. You can watch the spread of local anesthetic, and if you're not quite happy, you can manipulate the needle to get better spread. So, in-plane technique from posterior, the interscaling area. The disadvantages is that you have this long tract through the tissue of the patient, and this could potentially be a problem when there's coagulation problems, and this is where your block choice would also be relevant. Patient discomfort, obviously you can overcome that with a bit of sedation and some analgesia, and then damage to surrounding tissues is also at risk. You're supposed to be able to see your needle all the time, but that's not necessarily the case. We're all learning, we're all making mistakes. So, which expert opinion are we going to follow? Are we going to have the British, North American in-plane technique, or are we going to do the European out-of-plane technique, or are we going to do what ADMIR does and just go in between the two continents and does both anyway? And I think I'll just go through the initial techniques and just say what I do and why I think what the evidence suggests as well might be a better technique, or maybe just a few things to consider. Bernard Morrigal, he's at the conference, and he's excellent, obviously, at ultrasound anatomy in Innsbruck, is where he's a professor of anatomy. And when you scan, you can only see what you know. And he knows a lot more anatomy than anybody else in this room, I suggest. And he sees things that we haven't even thought about. If we talk about the interscaling out of plane, very similar. It's a very short distance. This nerve root of C5 is less than half a centimetre below the skin. So it should make sense, it should be nice and easy just to put the needle behind the nerve plexus, inject a bit of local anesthetic. There are other structures there as well, so it could be quite easy. We look at the in-plane technique, and I'm sure many of you, is there a show of hands who uses the in-plane technique for interscaling? Okay. Who uses the out-of-plane technique for interscaling? Okay. I'll give you my opinion in a moment, but if you're using the in-plane technique, there are a few other considerations that you should make. If you look at the suprascapular nerve, that's what we want there. Nice picture of the brachial plexus. But have you ever thought about the long thoracic and the dorsal scapular nerve? Has that ever crossed your mind? Yes? Good. Then you're enlightened and you can use an in-plane technique, I think. But if you didn't know about these things, coming back to our anatomy, it's never bothered you. I've seen many people stick a needle right through the muscle of scalenus medius, which is where you would find these nerves, not knowing that these nerves run in this particular muscle when you're doing a posterior approach to the in-plane technique. So just a rough picture, somewhere there, and they will come backwards. And these are sort of nerves that we do need to consider when you're using an in-plane technique. They supply the serratus anterior muscle and the rhomboids and the vagus scapular sort of muscles. And it'll look something similar to this. So you will see a plexus there, you can't see that very well, but you can maybe see a nice big bright white structure in the scalenus medius muscle there. So if you see something bright and white, don't put your needle through it. If you do, this is the potential case reports that you can be writing for next year's meeting. So they have been written already, and it says confirmed case of injury to long thoracic nerve. If you actually read the article, it's not confirmed, it's suspected, so that hasn't actually been completely verified. Also the dorsal scapular nerve injury, again, blaming it as a complication of the ultrasound-guided or in-plane technique. The reports are not convincing, and I think there is a systematic identification process. If you start scanning and look for these things, again, coming back to what you don't know, you won't see. If you know about these nerves, you will now look for them, and you will try and avoid them when you placing your needle. Maybe that is an argument why we should be using nerve stimulation with our ultrasound anyway. Just a show of hands, who uses routinely nerve stimulation with ultrasound? Okay. So, this is a scan. You get a nice plexus there, and you can see some movement of a bright white structure in the fascial plane, in scalenus medius. So when I actually enter my needle there, I'm going to avoid this bit. So I normally try and come on the top half of scalenus medius when I do an in-plane posterior approach. When we get to the supraclavicular area, I've not had many arguments about this particular block. I've not seen many descriptions of using an out-of-plane technique for this. I think everybody is quite happy with an in-plane technique. And if you look at the vascular structures, or what I would call tiger territory, there's lots of structures that you can damage. It is quite important to visualize your needle quite clearly when you're performing this block. So there you have your neurovascular bundle. That's the particular area. We're aiming for that so-called corner pocket, which is right above the rib and the subclavian artery. But again, have you considered the transverse cervical artery? Often that artery divides the plexus into different areas that can influence the spread of local anesthetic. And I think in the past, when the hematoma rate for landmark techniques were very high, I think you weren't actually hitting the subclavian artery, you were potentially hitting the transverse cervical artery, because sometimes that can be quite just as big as the subclavian. So again, if we look at the block performance here, all the dangerous structures that you want to try and avoid, the artery and the lung, is clearly visible. All we need to do now is see our needle, which is not there yet, and there it goes. So, the needle, again, this is an interesting block, because where do you actually have the endpoint for this needle? I think Big Lyson has written quite a few reports about what's called intraneural injection. I wouldn't suggest that, because I think that's an injection near the plexus. Anyway, but you can see where your needle tip is. Quite confident I haven't damaged the pleura, quite confident I haven't damaged the blood vessel. Not everybody is that lucky, and there's case reports with ultrasound of pneumothorax, and this is a terrible outcome for a patient, especially if they were expecting to get ambulatory or day case surgery. The infraclavicular area Again, I just put this picture up because this is the clearest I've ever seen these particular nerves. So there's the pleura, there's your three chords, your pec muscles, and I'm trying to look, there are multiple descriptions of getting to these particular nerves. But the consensus seems to be an inline approach in this deltopectoral groove. So the needle is quite a steep angle, and I think this is where the ultrasound needles, the etching, the laser etching, has really made a difference, because they are now a lot more visible at a much steeper angle, because there's not much space there between the clavicle and the coracoid process. Sometimes you can give yourself slightly more space if you use a 25mm probe instead of the traditional 35 or 50mm probe. Again, there is also descriptions of people injecting the needle underneath the clavicle. So they actually start above the clavicle and inject underneath. I wouldn't suggest that just yet. The axillary area, there's obviously two options there. And this is a very vascular area, so when you do your initial scan, your ulnar component might be completely covered with venous structures or arterial structures, so it might be very difficult to get your needle from an in-plane technique all the way to the ulnar nerve. This is the sort of block recognition that we would want. Normally between the artery and the skin, you'll find the median, between the vein and the artery, the ulnar component, and then posterior to that, the radial component. But that's not very consistent either, only about 56% of the time. And this is a study from the Vienna group. So, again, you can see the needle coming in quite nicely. You can create a bit of space, advance your needle, look at the nerves, look where the veins are, and obviously when you're pushing down the ultrasound machine you are collapsing those veins, and then you can pick the nerves individually and surround them with local anesthetic. If you lose your needle tip because of maybe patient movement or breathing, then obviously you stop and carry on from there. One of the reasons I do use an in-plane technique and come from the biceps side is because of the musculocutaneous nerve. As we know, for orthopedic surgery you often do need to block this, not just for tourniquet pain, and it's in this fascial plane between the coracobrachialis and the short head of biceps. And it's a variable distance. Sometimes you see it right next to the neurovascular bundle where the artery is, and sometimes it's quite a distance away. And but with a in-plane technique, you can often find that. This is hopefully a good example of hydrodissection, and how I like not to get too close to the nerve, but let the local anesthetic dissect around the nerve in that fascial plane. And then you'll have confidence that the block will hopefully or definitely work. I could have stopped at that particular point, but I was having such a good day that I decided to, because I've only injected about 3 mils, and I thought I'll just do one more for luck underneath. But if you are scanning properly, then you'll get this reverberation in the needle, and you're very confident then that your needle tip is not causing trouble. Just a few of the peripheral nerves, you can do them in-plane or out-of-plane. I am slightly biased. I do most of my nerve blocks in-plane, and you can do in-plane from anterior or posterior to the radial nerve. The median nerve is an interesting thing because I used to do it in-plane, and then I kept on having to divert the course of my needle because on either side you have the ulnar and the radial artery, which is often in the needle path, and you, as you put your needle into the skin, puncture those vessels. So you do an arterial line before you even know it. So out-of-plane technique for the median nerve is what I do at the moment, or I definitely scan and avoid those structures. If we go to the lower limb, This is a picture of the femoral nerve from the lateral side being done in plane. And this is probably one of the nerve blocks that people learn or teach initially when you're doing orthopedic trauma. And a lot of people are very comfortable using a short axis technique and very reluctant to move on to a in-plane technique. Admir Hatzig and Sala Blancha did a study looking at the comparison about intraneural or potential intraneural injection, but actually it was more looking at nerve contact, because the study obviously wasn't big enough to show nerve injury, but they looked at small things like paresthesia, nerve contact, and they found that there was less nerve contact with an in-plane technique, and that's really because as you pop through the fascia iliaca, you obviously had a little bit of lack of control and could potentially have a lot of nerve contact or overshoot into the femoral component. Again, I normally aim for fascial plane coming in from lateral. My initial injection is there. I'm not entirely happy. I think I can do better because I'm not convinced that I've actually gone through the fascia iliaca just yet. So I'm aiming for the apex, and in a moment you'll see that there is a much more definite fascial plane that's been removed. So now this is hydrodissection over the femoral nerve, and normally I find you don't have to surround it posterior or anterior. That coverage will normally be enough. And there you can see the needle tip. You've created the space with the local anesthetic, and I feel this helps with the safety of the block performance. Okay, one thing to remember when you do use an in-plane technique, after I've told you how wonderful it is to know about some arteries. And again, we've forgotten about the circumflex femoral arteries up in the thigh, and these are the sort of things that we can hit when we do an in-plane and possibly out-of-plane technique, and that's the sort of result when you're not careful. Obviously there's all sorts of other new blocks coming onto the market now, the ductal canal block, and again, this is just a British publication, and you can see that they've gone for the in-plane technique there. The sciatic nerve is interesting as well because it's a deep nerve, so out of plane often makes a lot more sense because it's the shortest distance between the skin and the nerve. So in that particular situation, there'll be nothing wrong with doing out of plane. But also, in-plane is acceptable when you're doing an infraclavicular, infragluteal block. It's quite superficial. And you can normally see the nerve reasonably easily in that particular area. And again, it just gives you a little bit of confidence that you can see the needle tip a little bit better. I won't bore you with too much of these. Now the popliteal, for me, ultrasound, this is the block where ultrasound has made the most difference in my practice. Maybe I just wasn't meticulous enough with the nerve stimulation technique. But popliteal has various options, and these are just two approaches. Unfortunately, I'm quite a lazy anaesthetist. I don't want to turn my patient too much. So I prefer just to make a leg raise. I went to our medical equipment department. I got them to make me a stand. You can see it goes to the other side of the bed so that you actually have lots of space to work. There's a bit of debate between some of the UK experts whether the leg should be bent or whether the leg should be straight. In my humble opinion, I think the nerves are slightly more superficial when the leg is straight, and even in quite big legs, it is quite superficial and easy to find the nerve. So you are now scanning from underneath and needling in plane from the lateral side. One little thing to remember, when you're scanning from underneath, your ultrasound image is still produced from the top. So you may, if you're clever enough, turn the picture completely around, or when you are doing the needle movement, you have to invert the needle movement. Something that you learn very quickly, but just something to remember. So that's my preferred technique for material blocks. The proviso here is when you're coming from the lateral side is that you've got the biceps femoris muscle and tendon. And you'll notice as the needle comes in here and you're getting just popped through that tendon, you almost overshoot slightly. So you'll see that. See that? If I was aiming directly at the nerve, potentially I could have damaged it. And now I see my needle tip. I do it at the bifurcation and try and get local anesthetic to spread and go into the what is classified as the paraneural sheath, even though that's probably not the correct terminology. And you'll see the local spreading quite nicely. Again, it's a hydrodissection technique. You can see it surrounding the common peroneal nerve. And now I can advance my needle into the potential space that I've created. Quite happy that I can see the bevel of my needle all the time. Okay. I think if you're not confident with this particular block, then don't go in between the nerves just yet. But I use that technique to place a catheter as well, which I'll show you in a moment. You can obviously do all the blocks in plane if you want to. Even the ankle blocks you can. Just when I do the tibial nerve block, it is quite difficult to do it in plane because the patient is normally lying supine. The Achilles tendon is right there, and it's very difficult to get your needle from the posterior side. Anterior is also difficult because you've got the posterior tibial artery in your way on the anterior side. So of the ankle blocks, this is possibly the one where I would use an out-of-plane technique, depending on how you can manipulate the foot of the patient. So that's maybe one extra one. Now paravertebral, I haven't even added the needles to this particular slide yet, which is courtesy of one of my friends. And these are just the probe positions. So all the publications, they haven't decided exactly which is the best needle advancement, but there's lots of different descriptions. Initially, majority of us were quite scared of angling the needle towards the neuraxial space. But when you're actually doing it in plane in this particular technique, you should be able to see your needle tip reasonably well and have confidence that you're not going to push it in too far. And then when you inject, you can see the pleura move down. Abdominal wall blocks, tap blocks, traditionally done in plane, even though the original description of the triangle of the T area that was done with landmark technique. And again, you see the needle coming in into the three muscles and trying to deposit that. So my friend Jens Borglum, he'll be talking about this block at some stage, I'm sure, during the meeting as well. And these are slightly deeper blocks. And if you then have an in-plane technique with the newer type of needles, you can follow the needle all the way to your quadratus lumborum or the transmuscular quadratus lumborum block. If you are scared of a curvilinear probe, it's not as daunting as you think. Use it, practice a little bit with it, and you can follow the needle quite easily with a curvilinear probe coming from posterior and in plane. So I do find when I'm doing the deep blocks that it is difficult to find the needle and see the needle all the time. So I sometimes use what is now, we thought about it this morning, the in-out-of-plane technique. So you are out of plane, but your needle is so steep next to the probe that it's actually almost visible. And this works actually a little bit better on the curvilinear probe. So if you have a deep lumbar plexus block, then sometimes this in-out-of-plane technique works reasonably well, keeping it very close to the probe and going almost 90 degrees. The serratus plane blocks, again, this is just to demonstrate that we tend to stick to the original description of a block. So if Ralph Blanco and Teresa Paris said we're using an in-plane technique for this to get to this particular fascial plane, then we do the block that way, and we end up staying that, and you tend to stick to your original motor muscle memory, and it's very difficult to change unless you have a complication or somebody else shows you a new technique. If we are looking at catheters, which I'll go through, I mean, in the UK, catheters are not used as much, I think, as in Europe and in North America. But catheters is quite controversial because are we going to place the catheter along the same axis as the nerve, like we traditionally have, or are we going to go across the nerve and then risk the catheter moving? If you look at the catheter placement, just at this, you normally find the position, thread the catheter 3 to 5 centimeters beyond it, and then your local anesthetic will still be there. And this is just a study to show that if your catheter insertion is not between 5 centimeters, but 3 to 5 centimeters, the rate of being dislodged is much higher. This is a study about comparing femoral nerve and blocks, catheter in plane, catheter out of plane. And this was done again by Fredrickson as well, showing that you can use either technique. I tend to, when I use a in-plane technique for my catheters, I tend to use a multi-hole catheter just to allow for some movement. And I think this is particularly important when you're doing interscaling, but this is just a picture of a femoral nerve catheter, catheter placed above the actual nerve, and I'm injecting through the catheter, watching the expansion of local anesthetic. I wouldn't suggest the coiling catheters just yet. I haven't got too much experience with them, but I think the multi-hole catheters for an in-plane catheter technique makes sense to me, because especially in the interscaling area, where you can have quite a lot of tissue movement, there's a great video clip that Adma showed me about this moving almost 2 centimeters. The chaps from block jocks, they have a technique what they call the Hickman flip, where they actually try and put a bit of extra catheter behind the plexus, posterior to the plexus. So if the patient does move their head, that'll compensate for it. So catheter fixation is very important when it comes to these things. There's a single-hole catheter, and I think the best thing about ultrasound and catheters is that you can actually see exactly where your local anesthetic is spreading. So I'm confirming my catheter placement with ultrasound. So this is an in-plane catheter technique. It is difficult keeping these catheters in place, especially in the interscaling area. I think the femoral area, where there's less movement of tissue, in plane might work better. The popliteal area again, a special consideration. If you place your catheter through the biceps femoris muscle, and there's a lot of muscle movement when the patient is walking or doing physiotherapy, then your risk of dislodgement is definitely higher. But I've had great success using an in-plane catheter placement. So, in summary, I think the technique that you like, that you've learned, that you love, is really the one that you've learned initially. We do change as we go along. I think it's important that you consider your surrounding anatomy. I think that's particularly relevant in the interscaling block. So if you're doing in-plane interscaling, definitely have a look for dangerous structures. Ensure that you can see your needle tip. This doesn't matter what technique you're using, do not advance your needle unless you can see it. Technology will help us in the future. There'll be green lights, red lights, yellow lights, all sorts of things telling us we're on the right target. Thank you very much for your time. And if you would like, can I invite you to Brighton next year in the UK, nice sunny holiday for a weekend, and we'll show you all of these techniques.